Hey, it's Dr. Amanda with Straightsmile Solutions, straightsmilesolutions.com. Let's talk about missing teeth and orthodontics. And for those of you who are out there, I actually have some other content on this. If you go to my YouTube channel, you can put in the keyword missing teeth or crown to root ratio. It might just be crown and root. I'm kind of just repurposing this content because I feel like people aren't understanding this. So I maybe need to explain it better. So I'm going to try to do my best. So I think it's tricky. You'll get these patients, and a lot of you guys are doing adult ortho cases because you think it's easier, because you think adults are easier. They're not. They're 10 times harder. The older the patient gets, the more interdisciplinary. I mean, there might be a higher ROI because you can get veneers and, implants and like a lot of revenue out of this one case that starts with ortho. But you need to be making sure you're picking the ortho case right, because sometimes you don't need to do ortho if you're doing a major interdisciplinary restorative case anyways, or sometimes it just makes it 10 million times harder that it is not something. Don't take the bait. It is not low-hanging fruit. It does not make the case easier. It actually makes the case 10 million times harder. The more bone you are, the first thing keep in mind, look at your crown to root ratio. This is just so simple. The more bone you are missing, the more unpredictable the case is going to be. Remember, teeth are like trees, okay? I've got trees in my backyard. I got plants in my backyard. It's really windy today. If I plant my little new hibiscus tree and not enough soil and there's wind, it is going to blow over, right? Because there's not enough soil. Just like in a case like this where these teeth are planted in bone, but in this case, they're only in, say, X amount of millimeters of bone. I don't know how many this is because this is like a PA of a picture, but you can see in this case, I would say 2/3 of the tooth is in bone, solid, and 1/3 is out, normal, okay? Anytime you get half or less support than half, where half the tooth is outside the bony housing, I'm not saying gum, I said bone, and less than half is in, that's a problem. Now we have an unbalance of force. And although I'm not a physics major, orthodontics is physics, and I can tell you things just don't move predictably. It doesn't matter if you are in braces or clear aligners. It does not move predictably, and it often just tips, and weird things happen, and sometimes you get damage that cannot be undone, and that is where the liability happens. And that is where this engine or whoever's treatment planning is running through some AI software, they are not going to know what is going to happen because they're not periodontists, nor are they actual real US licensed orthodontists. They're often bots, or they're orthodontists in other countries who really don't know or care what happens to your patient's teeth. And they don't really care if you get sued, lose your license, or get an insurance complaint. And that is the honest truth, because they are owned by private equity, and it is your job as a dentist to know how to move teeth. They are giving you a tool. It's your job to learn how to use it. They may have a training program, but their training program may be trash. And it may not go over the things that could happen. And that is why I make my channel, is to warn you of the things that can happen and to remind you, even if you're trying to fast track and do clear aligners and just skip over learning all the braces, guess what? You will never understand clear aligners if you do not understand braces in phase 1 interceptive. You will make many, many, many mistakes unless you have someone who knows what they're doing your plans for you. So either you need to learn how to do it, or somebody who knows what they're doing needs to help you do it. It will not work any other way. And the margins are so slim right now in clear aligners. 10, 15 years ago, it was profitable. It is so not profitable now. It is not. It's only profitable as the means to an end for more work, either more aftercare monetization, more, cosmetic monetization, or whatever. Is phase 1 interceptive profitable? Absolutely. Phase 1 interceptive is very profitable if you're doing it properly. You will get a slam dunk easy phase 2 out of it. You get 2 for 1. They pay for both. You probably get all the siblings. That is where the low hanging fruit is right now. This is not where the low hanging fruit is. I would run away from these as fast as possible and give these to your most unfavored orthodontist or educational program, or you send it to profs, or you just do a profs case, right? And get a lot of revenue. Okay. So that's basically what I wanted to tell you high level. Now I'm going to go a little bit more into the research and nerd out a little bit. And of course, I'm going to be reading some literature as I do this, or just explaining the literature. But other thing to keep in mind, let's say there was a case. In most of these cases, look, you're missing so many teeth anyways. If you only have 5 or 6 teeth on a top arch and 5 or 6 teeth on a bottom arch, I would say if you're missing any more than, not wisdom teeth, but say 7 to 7, okay? 7 to 7, 7 plus 7 is 14, okay? If you're missing more than 4 or 5 teeth per arch, where you're supposed to have 14 teeth, I'm not worried about the 16 teeth. I'm talking about the 14 teeth. 2 molars, 2 premolars, 6 anterior teeth on each one. You get the idea. I'm counting as I go. So if you're missing more than a few teeth per arch, it is already incredibly unpredictable. If you layer on this a crown to root ratio and bone loss, forget it. You don't want this case, run away. Sometimes you don't have a choice, okay? There are some situations where maybe there's just this anterior crossbite, and if we're gonna do the full mouth restorative or whatever, we're gonna have to pull it, or we're gonna have to endo it in order to crown prep it. Okay, yeah, then I get it. Then maybe now this is a choice. Is it worth the 6 to 9 months to a year and the money and the lab fee and the time to do this, or is it better to just do it full restorative? That's really up to you and the patient. I mean, you'd have to work up the case. Sometimes you can just do an upper only, sometimes you can just do a limited only, sometimes it's not worth it. And a lot of times these fail. I would say the chance of these failing is high. So that's where it gets messy. It works okay when it works out. When it fails, often the whole thing explodes in your face. It's often way, way better just to send these limited cases, to an orthodontist who's going to work with a prosthodontist. And if it fails in this case, they both have all the predictive stuff, everything they need, and they already are, especially even better if you send them to either a pros residency or an ortho residency, and an ortho and a pros residency. I would do that because nobody's having trouble there, because that's education and it's research. So, okay. So, and also, I mean, to be honest, all the planning, unless you are locked into that restorative and they've paid up front, a lot of times they bail on the restorative and then you don't get your money anyways. So, it's kind of hard to charge it if you haven't already prepped it. So keep that in mind. Okay. And then, like I said before, in a lot of these cases, there's a reason they're missing teeth. It's usually perio. So you don't want that case anyways. But occasionally you'll get a young person that just has anodontia, a few missing teeth. We really don't have a choice. Heck yeah, we're going to do that case in that case. We're going to do it. But we got to do it young, when they're young and healthy, not when they're old and the bone's funky and they're already taking weird medications and make it unpredictable and everything like that. So, okay. So nerding out a little bit more. Let's go into why this is the case. And if you aren't understanding already, I mean, like I said, I'm not a physics expert. I'm going to try my best to explain it in my own words, just based on my own orthodontic knowledge. Just trust me, it doesn't work. But so when you have missing anchorage, and then you've got Newton's third law, orthodontics relies on anchor groups of teeth to move target of teeth predictably. Once a patient is missing a third to a half of their own natural dentition, your anchorage pool evaporates, because every action there's an equal and opposite reaction. Applying a force without sufficient adjacent tooth mass or a stable moment to force ratio causes the entire system to collapse. In clear aligners or wires alike, the lack of proximal structural proximity means teeth will not translate or simply drift. You will have to try to move them, but if you don't have the right crown to root ratio, it just falls over anyways. When a patient has lost their teeth due to periodontal disease or severe decay rather than congenital absence, the remaining teeth almost always suffer from horizontal or vertical bone loss that often degrades the crown to root ratio. Bone loss moves the tooth center of resistance to a much closer to the apex of the root, and when standard orthodontic force is applied to a long clinical crown with an embedded short root, the force creates a massive uncontrolled tipping moment. Instead of body translation, the tooth tips violently, destroying the little crust of bone remains. Yes, okay, you get the idea. Okay, so basically, not a good idea. Don't take the case. Goodbye. Do pros. That's all I got to say. Don't take the bait. Thanks.